You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she is also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, everyone, and welcome to the podcast Myelofibrosis for Medscape in Discussion. We are back with our episode 4, and the guest speaker today is Dr. Raajit Rampal at Memorial Sloan Kettering. Dr. Rampal is a hemoncologist who specializes in the treatment of myeloproliferative neoplasms and leukemia at Memorial Sloan Kettering Cancer Center. He's also the director of the Center for Hematological Malignancies and director of the Myeloproliferative Neoplasms program there. I've spent a year in his clinic learning all about MPNs, which certainly gave me a good start when I was starting my faculty position. So we're very grateful to you, Dr. Rampal, for joining, and thank you again for coming on.
It is absolutely a pleasure to be with you, Tania. And thank you for having me.
Let's get started. The topic for today is TP53 and post-MPN AML, and I think we'll try to capture just high-risk MPN and advanced MPNs in general. Before we get there, though, I do want to congratulate you on your successful completion and leading the Manifest study, and I believe it's in the works for future development in terms of publications and hopefully getting to patients. That must feel like a relief.
Thank you for that. I mean, obviously, for a 400-patient trial, there was a lot of people involved, right? I think there's some interesting, promising data. As you said, the hope is that this benefits patients.
Absolutely. And we look forward to hearing more and more about it. Talking about high-risk mutations, let's start, if you don't mind sharing, what you think of as high-risk mutations and MPNs, and how do you handle a clinical scenario when you see one of those pop up in the NGS or your mutational analyses?
You know, it's an interesting and it's a complicated question, right? You know, we have had the dogma for the last, I could say, probably about a decade, right? That high-risk mutations are, you know, ASXL1 and EZH and IDH1 and 2 and SRSF2. But I think one of the cautions, there's multiple cautions here. One is that the first set of data came from a time period where we would sequence a panel of 30 genes or 40 genes, and that was state of the art. And that's just not true anymore, right? It's more than just, you know, that. I think we're coming upon the time where things like whole genome sequencing will actually be used in the clinic. And as that happens, the spectrum of what we find will change, and along with that, the spectrum of what is significant, either positively or negatively, will change. So we have to be cognizant of that. The second thing is that I think context matters. We always have to remember where the initial data came from, what was the initial training cohort, and also ask the question, does that pertain to all different sets of patients? And a good example of this is ASXL1. ASXL1 is known to be a bad mutation in multiple myeloid malignancies, right, in AML and MDS. But when you look into some of the more recent data with regards to ASXL1, there does seem to be some difference in terms of its impact, whether one has primary myelofibrosis or a secondary myelofibrosis. There's some, you know, data from Jean-Jacques Kelagian's group on this, which seems to indicate that it may not have the same implications if one has the secondary myelofibrosis. Is it reasonable to think of these four groups of mutations as still high risk? Yes, but, right? So I think that we can't think of this in a black and white manner. The other point when thinking about context to be made here is what does the totality of the picture look like? In other words, if one considers the clinical variables, the cytogenetics, and the molecular genetics, you are more likely, I think, to come up with a useful synopsis of what the patient's risk is. I think we all have patients who we follow for years who have one of these mutations. And we wonder, well, why is this patient doing so well? Why they shouldn't be, right? They have an ASXL1 mutation. But again, I think part of that is the context matters. And then I think the last thing I would say with regards to this part of this is that the type of variant may matter, right? It may not be that all of these variants have the same pathogenicity. ASXL1, again, there's a number of variants, some of which are controversial in terms of whether or not they're actually pathogenic or not. Rather than answer your question, I've created a lot more confusion, but that's the reality of things is that I think there is a lot of confusion here. There are other mutations, right, that we have identified that also seem to have prognostic impact. Things like U2AF1 mutations and also RAS pathway mutations. Multiple papers from our group and other groups that have shown that RAS pathway mutations are associated with a poor prognosis. This list is going to increase.
I totally agree. And I think even though we don't include some of these in when we think about the standard risk metrics, I think they certainly raise an alarm when you see them on the sequencing results, appropriately so. So let's talk a little bit about TP53, and you've obviously done a lot of work in that space, going back to your 2014 paper, developing these mouse models and demonstrating that when you add TP53 to the JAK2 V617 allele, that almost invariably transforms into AML. When we think about it in a clinical scenario, we think about that for sure. And then we also, as you probably alluded to a little while ago as well, we also have patients who have chronic phase disease with TP53 and do not immediately develop AML. How do you think about those situations? Can you shed some light on that for our understanding a little bit?
Yeah, it's interesting. It's not uncommon that I see patients who are referred in from the community because they're found to have a P53 mutation and they have PV or ET or sometimes MF. And the question is, okay, now what? Should we transplant this patient? What do we do with this patient? It's an important question, right? Fortunately, P53 in chronic phase is not a common thing, right? It looks like it's probably, the frequency is around 3 to 4% of patients in chronic phase. I think there's a couple of lines of evidence to consider. One is, let's start with the biology, right? As you've alluded to, we've published now a couple of papers making different mouse models. The most recent paper by my former postdoc, Bing Li, from Blood from about 2 years ago, we made an allelic series of mice, meaning that we took mice with JAK2 and we crossed them either with point mutants of P53 or with loss of P53 alleles in a heterozygous manner or in a hemizygous manner, meaning that you have a point mutation plus loss of the other allele. And we characterized those mice. And what we learned, one of the important things we learned is that the mice that have only one P53 mutation or who only have loss of one P53 allele don't progress to leukemia. And, we follow these mice for about 6 months, which in a mouse lifespan is a long time. They stay in chronic phase disease. But the mice that had the biallelic hits, so either loss of both alleles or mutation in one allele and a deletion of the other allele, which is more akin to what we see in humans, those mice invariably progress to acute leukemia. So that was very, I think, important and telling to us that it seems like loss or corruption of both alleles is both necessary and sufficient to procure leukemia, at least in a murine model. How do you translate that into patients and people? What do we know? Well, there is some data, and there is a paper from a number of years ago from a group in Poland that looked at patients with P53 mutations. And they followed these patients for, I think it was about up to 5 years, if I recall correctly. And what they found was that there was actually a fairly low incidence of progression in those patients. In other words, having a P53 mutation, it does not invariably lead to a diagnosis of leukemia, but rather that a number of these patients are able to stay in chronic phase for a number of years. And maybe the last piece of evidence that I would enter into the record here, it came from a clinical trial, and this was sort of an accident of the trial, but this is from the Myeloproliferative Neoplasms Research Consortium that we're part of, that looked at MDM2 inhibitors, right? So MDM2 inhibitors, the thought is They will allow for an increased expression of P53 by disrupting the degradation of P53. But one thing that came out of that study was that several patients actually had a marked rise in P53 mutation. Now, it doesn't look like P53 mutations were caused by the drug, but rather that these were really highly subclonal events that they weren't actually picked up on NGS, but you actually had to dive into the actual reads to find that the variant was there. But under the pressure of the MDM2 inhibitor, these were actually able to increase to the point where the VAF was like, in the teens or maybe in the 20s. So that was an important finding, that we saw in the context of MDM2 inhibition. But the point here is that those patients didn't progress, right? So even in the face of causing the P53 mutations to sort of become more clonally dominant, the patients didn't progress. All of which is to say that you need other things to happen. And so I think when we think about this in the clinical context, the finding of the single mutation by itself is not of any immediate concern, I don't think, provided that you're not dealing with a complex karyotype or a clear biallelic event. And so we may want to think about those patients differently than we want to think about patients, who do have the complex karyotype or the deletion 17p in conjunction with the P53 mutants.
Absolutely. That makes a lot of sense. If I could sort of steer the conversation a little bit in the direction of advanced MPNs or accelerated blast phase MPNs, which probably develop as a result of TP53 or otherwise, you've published some work on aza-venetoclax in that space. How are you managing patients with accelerated phase and blast phase MPN in 2024?
Yeah, I mean, this is clearly an area where we need to do better. I mean, the outcomes are still suboptimal. Suboptimal is maybe a polite way of saying, that we need to do better. The first question to me always is, are we going to take this patient to transplant? Can we cure a patient with transplant? That's your first question. The answer is yes, you can. And even if you look at patients who aren't in remission, who go to allogeneic stem cell transplant, you can still cure about 20% of those patients, meaning 5-year survival is maintained. Is a patient a transplant candidate? That to me is question one. If they are, then being aggressive, if it is clinically and genetically appropriate, and I'll come back to that in a second, is a reasonable thing. If the patient is not a transplant candidate, then I think we're really thinking more about palliation and trying to prolong life as best we can. And this is an important concept that comes from the paper by James Kennedy and Vikas Gupta a number of years ago, which demonstrated that if you take a patient, you give them an intensive regimen and you procure a remission, their outcome is no better than if you had done just an HMA or supportive care if you don't consolidate with transplant. And that to me is a very significant finding because that kind of tells us how you need to think about approaching this. In other words, you could take somebody and give them induction therapy and put them in remission, but if you aren't consolidating with transplant, you've done them no favor. You've cost them hospitalization and toxicities and infections. So that to me is question one. Now, patients who have, biallelic P53, these are not patients who are likely to respond to any type of conventional induction chemotherapy regimen. We know this from, de novo AML studies as well. And those patients should always, I think, be prioritized to a clinical trial if possible. But HMA-VEN could be considered in such patients, knowing that remission can be achieved, but it's going to be not a durable remission. And so taking patients like that and getting them to transplant early on is important. One can think a little bit here about which HMA you use, because, of course, there is this data that came out of WashU that decitabine, when used in P53 mutant MDS and AML, may not have inferior outcomes to other HMAs. And in fact, when we did the clinical phase 1 and phase 2 trial of decitabine and ruxolitinib, that was also our finding, that the presence of the P53 mutations did not incur an inferior outcome versus those patients who did not have P53 mutations with using decitabine, right? So that, I think, at least enters into the conversation. The outcomes, if you look across the board with HMA venetoclax, now from a number of series, about three big series, one from Mayo, one from MD Anderson, and one that was MSK plus a couple of other centers, showed that, the response rate, if you look at the remission rate, roughly about 40%. So certainly not what we see with de novo AML, but also not zero. And so I think HMA venetoclax is a reasonable option for many of these patients, accelerated and blast phase. HMA ruxolitinib, when we've studied it and the MD Anderson has studied it, the remission rates are, in the ballpark of 30-ish%, maybe a little bit more than that. I think that regimen is a useful regimen, more so in patients who aren't transplant candidates, you are largely trying to palliate. And, the median survival in those studies was closer to 9 months, which is better than historical normals. It's not great, but it's better than historical normal. Many of these patients, even though the Rux may not be doing a lot, my observation has been sometimes you withdraw the ruxolitinib and the disease becomes quite aggressive very quickly. So I think that is still a very reasonable regimen. And there is some data about combining Rux, venetoclax, and HMA. There's one published study, and we've done this now in a number of patients as well. It's hard to know how that really compares, but it seems to be a tolerable regimen. There's actually preclinical data to support venetoclax and ruxolitinib in combination. The thing that is the maybe bit of silver lining is IDH. IDH mutations are about 20% of these patients. The responses are actually reasonably good. There's a couple of different papers, one from MD Anderson, one from the University of Chicago, that have looked at this and seen some durable responses. And we've also just completed a study of ruxolitinib and enasidenib in IDH2 mutated patients and seen promising results. So those patients who are IDH2 mutated, I think it is a reasonable thing to think about, an IDH inhibitor plus or minus ruxolitinib as a therapy for those patients. The bottom line here is it depends on who the patient is, what you're trying to achieve with that patient.
I totally agree. I think we have maybe a couple or so patients who we did the trio of HMA and ruxolitinib, and as uncomfortable as I was at the thought of it, it was actually not as, obviously toxicity was a concern. It was not seen to have any additional or more toxicity or worse cytopenias than what we would have imagined with a combination of the two rather than the three. In fact, one of those patients we were able to take to transplant because we were able to get the disease in a stable position enough to do that. We've also done, and I'd love to get your thoughts on this, we've also done weekly HMA venetoclax based on some of the recent data in people with more so with complex cytogenetics and TP53, and not just in secondary AML, AML emerging out of MPN, but in general AML also in that combination. Is that a strategy that you've been using?
This is an interesting point, right? I've been fascinated by this paper that was in CCR from the Einstein group. The way so many of these drugs are developed is based on conventional concepts of how chemotherapy works, but HMAs may not work that way. And there's a body of literature behind this. So there is a rationale behind the dosing, the weekly dosing. And if you look at that paper, right, the toxicities were less and the ostensible remission rates were about the same, compared to other studies. I know they're looking at this prospectively at this point. So yes, I've started using this actually in very cytopenic patients who have more advanced disease. And I found that it is tolerable. I found that you can get things like spleen shrinkage and sometimes some hematologic improvement, but it is tolerable. In other words, these are patients that I would be very frightened of trying to use conventional HMA dosing, and because I know that they're going to become profoundly cytopenic, but we've been able to get away with it with minimal transfusion. So I'm actually quite interested in this idea.
Absolutely. And I think people, as you mentioned earlier, thinking about people who could go to transplant versus who couldn't, I think the ones where we do not see transplant as being the next step, I think for them, this certainly makes a lot of sense. While we figure out whether or how much transplant has a role in these very aggressive TP53 complex cytogenetic. I will circle back a little bit briefly in the time that we have on TP53 mutated MPNs, and I'd love to get your thoughts on the paper from Adam Mead's group that talks about inflammation or chronic inflammation promoting TP53 and potentially the consequences of that. How do you interpret that, and how do you, potentially use that?
Yeah, and I think that was really elegant work, where they did single cell sequencing that encompassed both RNA and DNA single cell seq in some patients who had progressed to AML that were P53 mutant. Their read from this was that there was an upregulation of inflammatory-related signatures, and so they tested this in vivo by giving mice LPS, which is a way to just provoke inflammation. This is certainly not a new concept in cancer, that inflammation may drive genetic corruption and disease progression. This has been seen with other genes. This has been studied in TALL, for example. But I think it's something that it hits home in MPN because we think about inflammation all the time, right? And it does kind of get at the question, if we have better JAK inhibitors and better anti-inflammatory drugs, could you actually subvert some of the genomic progression? It's an open question, but I think it's a good question.
And I think that is where the role of JAK inhibitors as being anti-inflammatory more than anything else also sort of comes to mind, right? How do we play those fancy anti-inflammatories into treatments of MPNs and potentially think about, delaying progression? Wonderful. Well, we're at time. I would probably conclude on that note. We enjoyed learning about TP53 and advanced MPNs from you, Dr. Rampal, and we totally appreciate you sharing your wealth of knowledge and going over the data that pertains to this. Thank you again. I appreciate all the audience listening to this as well, and we'll come back with our next episode number 5, in a few days.
Thanks so much for having me. I appreciate the opportunity.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.